Hello, everyone. My name is Orit Wimpfheimer, and I'm Chief Medical Officer at Nanox AI. And on behalf of Nanox AI and SCCT, I welcome you to our webinar, Novel Opportunities Using AI in Identifying New Patients with Coronary Artery Calcium. Hello, everyone. I'd like to introduce myself a little more in depth and then the rest of the panelists. So I'm a radiologist by training. I trained in New York Presbyterian Hospital. About 5 or 6 years ago, I wanted to get involved in artificial intelligence because as a radiologist, I really believe that artificial intelligence is the future. And if any radiologist that does not embrace AI and help form AI to something that we can work with is going to be left behind. So I became Chief Medical Officer of what was called Zebra Medical Imaging and has transformed into Nanox AI. Welcome, everyone. Ron, would you like to introduce yourself?
Yeah, hi everyone. My name is Ron Blankstein. I am the Director of Cardiac CT at Brigham and Women's Hospital, where I also am the Associate Director of the Cardiovascular Imaging Program, and I also work as a preventive cardiologist there. I'm a professor of medicine and radiology at Harvard Medical School and a prior president of SCCT.
Thank you. And Dr. Langholz, how about you?
Oh, thank you. Yeah, David Langholz. I'm a practicing cardiologist with Corewell Health in the imaging section as well as general cardiology section. I'm also a clinical professor at Michigan State University, and my role here was heading up the medical side of our AI implementation project as part of our population health system within the Corwell Health system.
Well, welcome, everyone. I'm just going to set the agenda for the webinar. We're going to have Dr. Blankstein first present a more academic perspective of coronary calcium and incidental evaluation using artificial intelligence and the benefit of doing that. I will then pop in and describe the product in detail and our experience in the past with prior SCCT posters and the data that we've accumulated. And then I'll pass over the speaking opportunity to Dr. Langholz, who will really go into depth of what we've accomplished at Corwell Health using the product with over a year of data at that site. So why don't you take it from here, Dr. Blankstein?
Great. Well, it's my pleasure to kind of kick off this session to talk about coronary atherosclerosis imaging and preventive cardiology, certainly a topic that I know is of interest to many of our SCCT members who are tuning in today. So I think we all know cardiovascular disease is the top cause of deaths in the U.S. Every 30 seconds or so, someone in the U.S. dies from cardiovascular disease. It seems though it doesn't often get the attention of the public until it's a famous celebrity like Tim Russert, the famous news reporter, or actors like the Sopranos actor James Gandolfini. However, one of the important points is that plaque actually builds up in coronary arteries decades before individuals have an event. And this is one of the reasons why a coronary artery calcium score is a very powerful test. It can detect atherosclerosis well before it causes any symptoms or any sequela. A calcium score is a very quick and easy test. No IV is needed. Similar radiation dose to a mammogram, it's a very low radiation dose. And it can allow us to detect the presence and amount of coronary calcifications. And it turns out that calcium score is actually the strongest predictor of future events of any test that we have today in cardiology. This has now been shown from data from multiple continents. So in the US, the biggest study, the multi-ethnic study of atherosclerosis, showed that when individuals have severe amount of coronary calcifications, they have a nearly 10-fold increase in their event rate, 10-fold meaning 1,000% higher. And not only does a calcium score predict the risk of cardiovascular events, it can also predict risk of non-cardiovascular events, and then specific cardiovascular events such as MI, stroke, revascularization, heart failure. It seems that almost every outcome we look at is associated with coronary calcifications. Importantly, when calcium score is elevated, that predicts a higher risk in both men and women. And one of the other points is that when we do identify calcium score or calcifications, clinicians actually act on that. So this is a slide that summarizes a meta-analysis that we conducted a few years ago, showing that when calcified plaque is detected, it leads to higher initiation or continuation of aspirin, lipid-lowering therapy, blood pressure-lowering therapies, increase in exercise, and dietary changes. Accordingly, calcium score now has a very important role in our guidelines. On this slide here, you can see the indication that's present in the 2018 cholesterol guideline and the 2019 prevention guideline, essentially stating that in intermediate or selected borderline risk adults, if the decision about statin use remains uncertain, it is reasonable to use a calcium score. So not a test that we use for everyone, but in selected cases, and this is becoming increasingly more commonly used in cardiology, but also in internal medicine. A similar indication has also been adopted by the National Lipid Association scientific statement, the endocrine guideline, and of course also the SCCT expert consensus statement. But we now have guidelines not just telling us that calcium score has an important role for estimating risk or for shared decision-making, but that when plaque is present, we should actually treat that. And this is actually something that's new because in the past, we used to kind of ignore plaque if a patient did not have obstructive disease or ischemia or actual prior events. We never really thought of that patient as being high risk, but we now have guidelines that indicate otherwise. Specifically in the 2021 chest pain guideline, there's a class 1 indication that for patients with non-obstructive coronary disease and stable chest pain, after all, this was a chest pain guideline, it is recommended to optimize preventive therapy. Similarly, in the 2023 guideline for the management of patients with chronic coronary disease is also defined in many ways, including imaging if plaque is detected by CT. One concept that is important is that when patients have a high enough calcium score, their risk is similar to patients who've already experienced a cardiovascular event, and therefore we can refer to those patients as having a secondary prevention goal. And this was supported by this study led by Matt Buda from the CONFIRM registry, showing that patients who had in the purple line a calcium score more than 300 had a similar level of risk as those who had established ASCVD, suggesting that we really need to treat these patients the same as we do patients who've already experienced a prior event. This is important because today when we evaluate a patient that has a high calcium score, it's not just about whether to prescribe them a statin or not. This is what people thought about a calcium score a decade ago. Do we really need to do this test to tell us who needs to be on a statin? But today in preventive cardiology, there's many other therapies that we will think of for a patient that has increased calcium score, particularly if it's moderate or severely elevated. In addition to exercise and diet, which is always the starting first place, we can also think of more aggressive lipid-lowering therapies, so high-intensity statins, or if statins are not enough, PCSK9 inhibitors, bempedoic acid, icosapent-ethyl. These are all agents that we may think of for a patient that has significant calcifications. In the future, also possibly lipoprotein A-lowering therapies. For that patient with high calcium score, we would also think of more aggressive diabetes management. For example, a GLP-1 receptor agonist, especially if they're also obese, or SGLT2 inhibitor, which also has been shown to reduce cardiovascular events, probably used more if that patient also has heart failure. We're going to target more aggressive blood pressure reduction if a patient has severe calcifications, as was done in the SPRINT trial. We're going to think about antiplatelet agents. We have at least observational data suggesting that if the calcium score is over 100, the role of aspirin may be thought of if that patient does not have significant contraindications in terms of bleeding risk. So a lot of therapies that we're able to provide our patients with coronary calcifications, and this list is going to continue to increase over time because there's more and more agents studied in clinical trials, and calcium score now is an important role in those trials as a possible way to be included in the trials. Now, the secret is about calcium score, and of course, I think everybody knows this who's tuning into the webinar today, is that you don't have to do a calcium score or a coronary CTA for that matter for some of our patients, because a chest CT may be sufficient. So this is an example here. If you just open a chest CT, a non-contrast chest CT, or even with contrast, you can see these calcifications in the coronary arteries. And I think many people who can look at this can estimate what is the calcium score and use that in patient management decisions. The problem is that when calcium score is present on non-cardiac scan, it is rarely reported. In some studies, reported about 5 to 10% of the time. And even when it is reported, it's often buried somewhere in the body of the report. Often the statement is there are coronary calcifications, and radiologists may not report the amount of calcifications. Of course, I don't think I'm talking to folks who are tuning in here, which is mostly cardiovascular radiologists who know exactly how to report and how to estimate. I'm talking about national statistics across the US that this is rarely reported, and as a result, very unlikely that anyone will ever act on that finding. So one of the approaches that can help, of course, is if we can identify incidental calcium. We call this incidental because these scans are not designed or not obtained to look at the coronary arteries. But if that incidental calcium is actually detected, AI can not only detect it, but it can quantify the amount of calcium score as 0, mild, moderate, or severe, using the very similar thresholds that we use when we apply calcium scores. The advantage of this is not just the ability to detect the presence and the amount of coronary calcifications, but it also improves the reproducibility and accuracy. If 2 or 3 different readers look at the same scan, they may actually quantify the amount of calcium differently if they do so visually, and an AI approach ensures better consistency. And ultimately, having this information can enhance risk assessment. It can help guide the use of preventive therapies. And I think this is something that will be very important in population-based preventive efforts, because one of the keys here is that these are CT scans that have already been acquired or already done for many other reasons. They're just sitting there in the PAC system and nobody's really paying attention to them. So this gives us another dimension to identify plaque, to identify at-risk patients. Now, there is a study here that I think is a really nice study done by a group at Stanford. Alex Sandhu led this study, was David Marin, looking at what happens when you actually provide patients and clinician information about incidental calcium score detection. This was a quality improvement project in Stanford. It's a single center study called the Notify One project. And what they found is that in patients who were not on statins, when this information was provided to the patients and clinicians, half of them were started on a statin thereafter, as opposed to the control group where only 7% was started. So I think this is really nice results. If we can find patients who have plaque, that did not know that they have plaque, and now at least half of them get started on therapy, that could have very big impact on patient outcomes. At Brigham and Women's Hospital, we are launching a study called AI Inform, and this is a multi-center trial designed to test the hypothesis that providing clinician information on the presence and amount of coronary artery calcifications will result in initiation or intensification in preventive therapies. So we are specifically including not just patients who are not on statins, we're also including patients who are on statin therapy, because we're interested to see whether finding this information will result in intensification of therapy or perhaps addition of other therapies beyond just statins. On this slide here is data from our center. This is from Brigham and Women's Hospital, just looking on the impact of notifying clinicians about the presence of a calcium score. And if you can look all the way on the right side here, when a calcium score is more than 100, 87% of our patients were ultimately on lipid-lowering therapies after the scan. But if you look at the light green bars, these are individuals who are actually on statin therapy before the calcium score. So 31% of patients who had a calcium score over 100 actually were on some sort of lipid-lowering therapy. And then when we look at them, 2/3 of them actually had an intensification in their therapy. So this suggests that finding calcium or finding atherosclerosis not only leads to initiation of statin therapy, which of course is very important, but in patients who may already be on lipid-lowering therapy, perhaps it improves compliance, but it also may lead to intensification of therapy. So in conclusion, incidental detection of calcium scoring using AI is based on imaging that's already acquired. It improves risk assessment beyond traditional risk factors and other biomarkers. It may serve as a powerful tool for population health management, and it can identify patients who are more likely to benefit from aggressive prevention measures. Now, this is an SCCT webinar, and I think like many people who are tuning in, I am also very excited, as I always am, to the annual scientific meeting, ASM. And this year at SCCT 2024, I just want to put a plug to 2 studies from our group looking at AI detection of calcium score using the Nanox AI technology. So one study led by Dr. Milena Petranovic from MGH, who's a thoracic radiologist, will look into AI-based detection of CAC on chest CT to enhance risk assessment among individuals with elevated lipoprotein A. So of course, lipoprotein A is getting a lot of attention as a marker of an increased risk, and we specifically are going to show some results on that. And then Dr. Brittany Weber, who's a preventive cardiologist at Brigham and Women's Hospital, who heads our cardiorheumatology program, will present an abstract on the frequency, prevalence, and outcomes of incidentally detected calcium using AI among patients with immune-mediated inflammatory diseases. And Dr. Weber is actually a finalist for the 2024 Canon Young Investigator Award. So I wish her luck on her presentation, as I also do to all the other Canon Young Investigator Award nominees. So with that, thank you all. We'll end it here, and I'll turn it over to our next speaker.
Well, thank you so much, Dr. Langstein. Part of the excitement of this product is that we could really make a very, very big difference. But in the SCCT, we're speaking to many physicians who are already aware of that. And that's still very important because we need champions across the medical industry to help get the message across. I come from the world of radiology, slightly outside the world of cardiac imaging. And my job is to try to get the information out there. And we're hoping with all the tools that provided in the webinar, you guys can help be our champions as well. I'm going to share my screen. Okay. As Chief Medical Officer of Nanox, I'd like to just present our product and our company just for a moment. Our entire platform for artificial intelligence is really taking CT scans and empowering radiologists to maximize the information from the CT scans, because just in the last 20, 30 years, the number of CT scans performed across the country and globally has increased exponentially. People are getting CT scans right and left for every possible reason. These days, it's almost hard to go to an ER for some acute problem and not come out with a CT scan. And yet there's a lot of information on those images that are not maximized by radiologists. And even though radiologists are doing a great job of reading the acute problem, cancer detection, a lot of things that are always mentioned, some of these chronic disease findings are not mentioned. And if they are, they're just lost in some long-winded report, and there's no actionable event that takes place for that patient. So all of our products focus on maximizing that data to be able to present it to the radiologist. And we've been working on this for a while now. We have several products of which we're talking about coronary calcium. And this is the first article that was just presented a few months ago that actually infiltrated the radiology journals rather than just the individual subspecialties. So there's a lot of information in the cardiology journals. Cardiologists and preventive cardiologists and cardiac imagers are well aware of the need for coronary calcium scoring and the ability to take incidental coronary calcium and maximize that information for patient care. But now we're slowly working our way into the radiology literature, because ultimately the radiologists are the ones that are going to be at the forefront of the vast majority of standard CT scans that come through the PAC system. This is an example of our product. Dr. Blankstein already showed it in brief, but I'll just go through it in detail. It analyzes all non-contrast, non-gated CT scans. It's seamlessly integrated into the PAC system. There's no clicks required by the radiologist. It automatically measures all the plaque within the heart and presents the segmentation to the radiologist or anyone looking at the study to show exactly where we measured, and then calculates the amount of Agassiz equivalent units and provides them into categories of 0 to 100 would be low, 100 to 400 would be moderate, and 400 and above would be high, providing that white index bar so that you can really see even within each category approximately where the patient falls. Because whereas the guidelines typically focus on general categories, sometimes that added little bit of information of 410 versus 2,000 might be useful for clinicians in deciding what to do with the patients. The results can be automatically put in the radiology report. Again, the goal is to make the radiologist not have to work hard in order to feel comfortable implementing this AI. So everything's done automatically without any additional clicks required in order to get the information across. We color-coded the algorithm, the results, so that it's easy for radiologists to not have to think so much and not focus on it so much. So gray would be the low category, the orange would be moderate, and the high would be severe. And that way the radiologist can either decide to look at the detailed information or just know that the report will say high calcium, and in looking at the standard axial images that they do anyways, know in the back of their mind that looking at the calcium, if they agree that it's a high amount, they don't have to bother going into the secondary capture series that provides the result, but it's always available should they be interested in doing that. Our new version that's actually being submitted to the FDA as we speak will have an additional category of 0. We found that 0 category for cardiologists is often useful, particularly in patients that have problems taking statins, a lot of side effects. And so if there's a 0 calcium, that's useful information. And we'll be also providing the actual score because we actually had feedback that whereas the cardiologists don't always need the score, the family practitioners are actually interested in the score. I'm not sure how that changes their management, but we're able to provide it because the algorithm calculates it anyways, and this way it'll be provided to the clinicians while they're reading the report. This is an example of what it looks like for the radiologist. It's integrated into the PACS as a secondary capture series. That makes it the most efficient. That's how it's implemented at Corewell Health and several other sites that we have. It's just present all the time. And again, you can go into the series and look at the details, as in this case, or you can just see red and know what will happen in your report and decide not to bother looking at it, knowing that you have high calcium while you're reading this study. Creating an automatic reporting system has become really critical for radiologists. Again, radiologists don't want to spend any extra time, so we work with each hospital system where we're implemented to decide on the verbiage that's attached to any of the findings. And that's really critical for our patient care because just saying high calcium does not send the patient to where they need to go. And we work with each institution to decide what we should attach to that as a recommendation. Follow up with your clinician, consider risk assessment by the cardiac clinic, whatever that institution would prefer to navigate the new patient flow that's coming in so that patients actually take the next step, follow up with their PCP or their internal medicine doctor or the cardiologist to know, to have additional assurance that the patient is going to get to where they need to go. And the way I like to view this product as well as our other products is really AI has become the bridge between two subspecialties that often don't speak the same language. Now, I know there's a lot of cardiac images on here, and you're the ideal, right? Because you speak radiology and you speak cardiology, and you don't need necessarily AI to do that work. But in the world out there where there's not really cardiac imagers that are reading the standard chest CTs that are coming through, this AI provides that bridge between radiologists that tend to either not report it as coronary artery calcium present, which frankly I do in my practice, because I don't have time to start analyzing a little, or being a mild, moderate, severe, which I personally tend to do when it's at the extremes. When it's moderate, so one person's moderate is the next person's mild, and the third radiologist severe. And so we're too general for actual clinical practice. And as a cardiologist, need all the guidelines-based therapies with the categories that are very, very useful for patient care. The AI does that work for you. And so the radiologist and cardiologist can then speak the same language using AI and then being able to treat the patient more ideally. I'd just like to touch base for a couple of minutes of previous presentations at the SCCT, because this has been a process of the last few years that we're really proud of. We started off at the SCCT in 2022 with a paper from Spectrum Health, where they just handed us 1 month worth of 549 CT scans. And of the 549 CT scans that we were given, non-contrast chest CTs, almost half the patients had a moderate or severe coronary calcium. And when we went back to the EMR, 153 of those patients were brand new patients. That was a significant number of new detected patients in the small cohort for the study. And that's what led Dr. Langholz and his team to really push forward as clinical champions within Spectrum, that's now called Corwell Health, to help push the AI product into the IDN and really improve patient care. And there'll be additional data that Dr. Langholz will be presenting shortly and that we will be presenting at the SCCT meeting in July. We then followed up in the SCCT in 2023 with a different type of hospital system. This is an HMO here in Israel. It's an HMO that's Kaiser-like. It's very focused on population health. And it took us a long time to convince them to do a study with us because they were absolutely certain of being so focused on population health that they catch the cardiac patients in lots of different ways, and they do not need this type of product instituted at the emergency room of a hospital system because it won't really make a difference. And we were able to show that it really did. Of the patients that were included in the study, so patients that were part of this HMO and had moderate or severe calcium, we ended up in just a couple of months with 101 patients that were brand new patients that had no diagnosis of cardiovascular disease before, and 88 patients who were brand new. And that's just a few months of a study. And so we've really made a very big impact. We've had many personal stories of patients that have come back to us and really thanked us for instituting the study so that they can be identified and detected. So that's just the past. Look forward to the future. And I'd like to hand over the baton to Dr. Langholz, who will speak from personal experience of the data at Corwell Health. Take it away.
Oh, thanks so much. And I am going to share my screen here in a minute. There we go. And well, thank you very much. And I wanted to, on behalf of Corewell, just to the opportunity to share our journey with everyone here today. And I'd like to shout out to Alexis and Tom Boyden that their help in pushing this through and making this a reality has been critical. So just a little bit about us. Corewell Health consists of 3 healthcare systems serving the southern half of Michigan. Corewell Health West, which is where we are, consists of 10 hospitals and 28 outpatient radiology centers. We also have our own payer. And we know it can be very tough to get your system leadership to invest in AI deployment in the clinical space. But several years ago, based on data that Dr. Blankstein referred to earlier, we were wondering about how to clinically implement AI into our own healthcare system to not only improve the healthcare of our patients, but also simultaneously reduce cost, which is the value proposition definition. So we made the case from 3 standpoints, which I outlined here. 1, the exponential growth of chronic disease needs to be managed prospectively for the individual patient using limited resources. 2, the need to shift to population health management as a system, and the need, 3, to manage insurance risk arrangements as we are getting more into risk-based arrangements. So this created the perfect opportunity for AI in our organization. Once we had convinced our leadership about that, we found that we needed an AI solution then that was vendor agnostic and had a track record for early disease detection. And Nanox met that need for a company. They are a company that has an established track record in healthcare AI. They could be flexible as our technology environment shifted and changed over time. And they were interested in partnering to find successful implementation solutions for our system. And their coronary calcium scoring algorithm had already received FDA clearance, and their AI algorithm met our 5 criteria that are listed on the right, with screening for specific disease, assessed disease burden, and lended itself into clinical integration into our system in order to guide and direct appropriate levels of service in a sustainable way that we'll talk about in a minute. So a helpful way to understand our implementation process uses a concept outlined by Paul Doherty and James Wilson from Accenture in their 2018 book, Human Plus Machine. On the right side of this pictorial, we were pretty confident that our AI end of the relationship was solid based on some work we had done with Nanox earlier. And on the left side of the screen, we knew our clinicians were doing a great job caring for coronary disease once it had been identified. However, like many healthcare systems, we had not solved the problem of connecting the AI-derived data on the right with the clinician on the left in a way that facilitated workflow, not adding to it, not hindering it. And this gap is referred to as the missing middle. And so to organize our implementation project on the missing middle concept, we divided the missing middle into 3 natural divisions, which I've listed here. And teams then were built around each of these 3 groups. And this is what the process looked like on paper to implement the Nanox AI functionality in a way that was both clinically sustainable and ensuring the full benefit of the AI is realized. So it's important to stop here, though, and emphasize that the process needs to create a multidisciplinary team of stakeholders. They're collaborating, allowing for multiple perspectives that help ensure that all potential downstream ripple effects from AI deployment are identified and planned for in a way that's conducive to both provider workflows and resource limitations. And we'll talk about that more in a minute. And we've outlined this work in more detail in a paper published last year on closing the loop in telehealth and medicine, if you're interested. So at a high level, if I can direct your attention to the left side of the screen, the scan is completed and the coronary calcium rating is determined in that data integration top portion. This level, this coronary calcium level, then goes into EPIC, which triggers a chart query to determine if the patient had an existing diagnosis of coronary disease. If they do not, then the ordering physician receives the notification of the information, the new diagnosis, and recommendations, as well as a link to appropriate clinical pathways. And let's look at each of these 3 sections then in a little bit more detail. So we have more than 80 radiologists who are responsible for reading the 60,000 chest and thoracic CT scans per year at Corewell Health West. So working with Nanox, our radiology physician champions, and our administrators within radiology, we designed and implemented the workflow which allowed the radiologists to familiarize themselves with and get comfortable using Nanox. The great thing about Nanox as a vendor is that it's agnostic in terms of its PAC system, and it was able to integrate seamlessly, which helped radiology workflow. The workflow we designed keeps the radiologist in the interpretation loop and allows the radiologist to read the CT study first so that there's no bias involved. Upon completion of that first read, the radiologist then quickly reviews the Nanox AI read. The radiologist chooses then whether the results should be included in the report. Once the results are in the radiologist's report, the report then goes for dissemination back to the ordering provider. Then the second piece, the validated findings then from radiology are extracted from PowerScribe and sent as discrete data fields into EPIC Chronicles. If findings were positive for either moderate or high coronary calcium scores, this triggers an automated chart query to determine if the patient already has an existing diagnosis of coronary disease. If the patient's chart met criteria for a pre-existing diagnosis of coronary disease, then no further action is taken. However, if no prior existing diagnosis was found, then a best practice alert or BPA was triggered to the patient's PCP, alerting them not only the new diagnosis, but also the coronary calcium score, and provided relevant recommendations that are specific to the severity of the results. Finally, as a third phase in the implementation, following a review of the findings and recommendations, the primary care physician or provider would then be able to determine the next best steps for each patient individually, being informed not just by the AI findings and the clinical pathway, but also by their intimate knowledge of the patient's risk factors and individual health goals. We believe this process allows for the ideal level of control by the PCP in how to use this data. And it's important to emphasize once again that the pathways were developed with our PCP leadership with careful consideration of their current available resources to help ensure that the pathway was sustainable from both the system standpoint as well as the individual provider perspective, and that it actually facilitated a positive patient experience. So this is how the primary care provider will see the results for the patients for whom coronary disease is a new diagnosis. Embedded, as you can see here in the bottom right, embedded within the report is a section called Nanox Results Available, Coronary Artery Disease Identified. It will clearly list the disease severity, whether moderate or high, and in this case it was moderate. And there's an active link to the clinical pathway. So the primary care provider who knows the patient, who has a relationship with the patient, will then guide decision-making on next steps, whether to initiate certain therapies, schedule an appointment with them, or send the patient on to preventative cardiology. And launching this month is a passive BPA that fires for the PCPs or APPs or cardiologists upon the chart being open in patients with new findings. We designed a BPA that automates several clinical and logical steps required in the patient management of coronary disease, allowing the clinician then to focus more on customization of the treatment plan and patient engagement. And so just to highlight two of these, the provider is able to add the new diagnosis or new problem with just a single click of the button without leaving the page. There's also in the smart set, a dynamic smart set based on patient results, including pre-checks of orders and what statin grouping is needed. If you look over to the right, this is how it opens. It will have links to metabolic wellness. It will bring up lab tests from the last 12 months if they're current. It'll display the last LDL cholesterol level in order to make decisions on. If it's moderate or high calcium scores, there will be appropriate statin medication recommendations. And then finally, there's an option for stress testing if the ordering provider felt it was necessary. So this implementation process did span 18 months. Not all of that, though, was due to development. Part of that delay was in time was due to Epic upgrades and freezes. But it was also done at a pace or cadence that allowed the various teams to do the important work of coalescing on processes and communication standards. This is not just a deployment of a new technology, but actually a change in how we care for patients. And we felt that taking time to allow for cultural change and acceptance by the various teams assigned to this work would help with broader adoption and acceptance, getting it right the first time, at least as much as we could. And so the last piece of integration and implementation is this dynamic BPA, which is going live this month. So finally, last but not least, we were concerned about patient perception and acceptance, as you heard from our two prior speakers, and into their own healthcare. We conducted a focus group before implementation and found concerns raised by patients outweighed perceived benefits. And so we were concerned initially that this may adversely affect adoption of treatment plans arising from the AI-derived data. However, what we had found instead post-implementation is that it's been just the opposite. Patients have shown a strong engagement when their own data was reviewed with them by their clinician. Nanox has an easy-to-see end-use interface that you've seen earlier in the presentation to display the coronary calcium imaging, highlighting the patient's coronary calcium in yellow and providing that estimate of coronary calcium score alongside the interactive image. We embedded the link to the patient's Nanox AI images within the results node to the provider, making it easy then for the provider to review with the patient in the office setting. And this ability truly closes the loop by tying the data acquisition on the front end of the process to the end user, the patient and their healthcare provider. And just a stop here for a minute just to share with you a couple of stories, even from my clinic yesterday. I had a 52-year-old woman that I saw who ended up having a chest CT done for non-cardiac related reasons. She had been concerned about coronary disease because of a family history, but her ASCVD score was not that high. And so she had not been sent on for any further testing. Her coronary calcium score was high when we had based off the Nanox-derived data off her chest CT scan. And when I showed her data, it was very validating about her concern and the ability then to be able to manage risk factors to provide progression or to prevent progression. Second, and on the opposite side, saw a patient yesterday who was reluctant to go on statin therapy for high lipids. The patient had a chest CT done for lung-related concerns. Calcium score came back quite high. I showed the images to the patient, and when he saw that, his comment was, and I included it as the top reason here, he said, "Boy, seeing is believing." He said, "I'm ready to take control of my disease." This tool really can be powerful to engage patients in what would be secondary prevention goals. So we went live December of 2022, and during the first full year of data, 2023, following the implementation process, we had just under 30,000 scans that were read by the algorithm. with approximately 12,000 returning medium or high coronary calcium scores. The agreement rate by the radiologist improved from about 61% at the beginning to about 80% over the same time frame, reflecting a greater confidence and comfortableness with the AI reading. And of the scans with positive findings, almost 2/3 or 64% were previously undiagnosed with coronary disease, and just almost 80% of those were not on statins at the time of the evaluation. These results, identifying just under 4,000 new patients with coronary disease, really does speak to the power of this technology and this process. When we look at who's ordering these scans, oncology was the department specialty leader in terms of ordering providers. However, if we combine family medicine and internal medicine, primary care was not too far behind. And most of these scans were CT thoraxes without contrast, and lung screening made up quite a few percentage of these. And for newly diagnosed patients with coronary disease, they were fairly evenly split between the medium and high coronary calcium severity ratings on the left side of your screen. The vast majority of them had end-of-life index score distributions under 10, indicating that we weren't identifying just patients with chronic or terminal disease for whom this information wouldn't be actionable. And interestingly, when you look to the right side of the screen, their ASCVD risk scores were split about in half, with half of those patients with moderate or high coronary calcium scores having a low calculated ASCVD risk score without the coronary calcium. And then in the first 6 months, in orange, in the first 6 months of implementation using coronary disease identified by radiology report only, and you saw this data from another system provided earlier, only 14% of our patients formally diagnosed with coronary disease, 27% started on statin therapy, and a small percentage referred to cardiology. However, when we had our advisory implemented, notifying the PCP of the results, these rates improved significantly, as you can see in blue. The success we've had with the deployment to date has occurred without the BPA being fully deployed, which is happening this month, and we anticipate that our numbers will actually further improve with that deployment. And to evaluate the clinical and financial impact of this AI use case and model, we plan to collect several leading, intermediate, and lagging metrics. The integration of AI findings as discrete data elements into the EMR will really help facilitate the ability to pull this information automatically into reporting and tracking data sets and their correlation over time in terms of impact on MI, CABG rates, and hospitalization rates will be powerful. And so to summarize, artificial intelligence's presence in imaging is expanding. And for those of you looking to introduce AI into your clinical care delivery system, identifying the clinical problem that best proves value to your organization will be important to identify so that you can prove value fairly early. Choosing the right vendor is critical. We found Nanox to be an excellent partner in this deployment every step along the way. Spending time making sure all stakeholders are at the table, defining strategic goals and downstream impact is critical. Different organizations are going to have different ideas related to these, depending on if they're fee-for-service or value-based, what their patient access issues are. I would also say that there needs to be consensus on who's going to own the results, regardless of who initially receives them, and that there needs to be strong leadership to get buy-in from those service lines that are impacted but not owners. In our case, that was pulmonary, oncology, and others. And finally, don't forget to embed ways to track whether you're delivering clinical benefit and economic utility downstream or not. That's going to be important to give that back to the C-suite people and have a governance process decided on early for dealing with issues that aren't going well. Once you have your first system down, in our case, it was coronary disease, then as you add AI algorithms for other chronic disease states, you can just template this. I'd really encourage you to head down this route. I think it would have a significant impact on clinical care delivery and tee you up well for what's coming in medicine. Thank you so much.
Thank you so much, Dr. Langholz. It's really fun to hear coming from you, all the different steps along the way, things we've improved, patients we've touched, and it's always gratifying because we really have had very, very close interactions with Dr. Langholz and many, many other members of Corewell Health, some of which Dr. Langholz mentioned, but there was a really large team all focused together to get this done. And I think we're making a really, really great impact. We're up to questions and answers right now. If anyone has any questions from the audience, feel free to send them our way. I do have a couple to start with. One of the challenges that we've had is really getting the word out, not to preventative cardiologists or not to cardiac imagers who are very well aware of what's going on, but to the more general cardiologists, the general radiologists, the general family practitioners. And I'm wondering if Dr. Blankstein or Dr. Langholz can comment as to what we can do better as a medical system, as industry, to try to kind of get the word out and get more hospital systems to follow the pathway of Corwell Health.
Well,
Dr. Langholz, maybe one of you.
Oh, please go ahead.
Well, I think it's always a challenge whenever you adopt a new technology, and some folks are early adopters and late adopters. But even calcium scoring, there are certainly healthcare systems and primary care physicians who it took them a while to kind of say, why do I need this? I can just kind of calculate a risk score. Doesn't this work? Does this work? And it took kind of a while for calcium scoring to be adopted. So I think, first of all, practices that are already using a calcium score who understand kind of how to use that are probably going to be earlier adopters of this technique. But ultimately, I think physicians kind of vote with their feet. They have a case and something really made a big difference. So they found, wow, this patient has a lot of plaque. I had no idea they have high LDL. They provide that information to the patient. It results in changes in therapy. And I think once a primary care physician has that experience, I think they're much more likely to kind of buy into it. So it is a one, you really have to kind of convince it a one by one, but really by using it, the more people start using it, the more they see the value. I think that's true of a lot of things in imaging. I would say the same thing on coronary CTA, since we're kind of at MSCCT meeting here. The more people use something and they find it useful, the more likely they are to use it again.
Yeah, I would echo those results. And I would add that having once a few of those providers, as Dr. Blankstein mentioned, have a positive experience, have those people become your physician champions and have them echo that to their partners. And that can, that's coming from their own team, and that can really engender a lot of enthusiasm when some of their own peers are having very positive experiences with this.
So we have one question from the audience. What is the financial model for the product, which is a really important point? The financial model is a subscription-based model, a yearly subscription based on volumes. So the number of CT scans you perform on a general average for a year. So it's a tiered subscription model. What we've added with our experience in Corewell Health is Corewell did a lot of the work with Epic integration and best practices. All that heavy lifting was on Corewell, but we've learned a lot in the process. So we do have the ability to just implement the AI and let the institutions do Epic integration kind of on their own and learn from Corewell Health and kind of be independent. Or we have learned from that experience and can offer Epic integration as well from the experience that we've had and vendors that we work with to provide assistance doing that, because some institutions find that a bit overwhelming. So there's the AI, and then there's Epic integration. Both of those are really important, as you've seen from Dr. Langholz's talk, to actually make it effective for patient care. The AI is just not independent, and it's not going to get anywhere if it's not a whole system-wide implementation.
Maybe just an additional, since we're talking about finances, the thing I didn't spend time on is that there is HCC coding reimbursement opportunities as well with the additional diagnosis if you have a system that has a payer affiliated with it.
Yeah. Does Corewell do annual screening based on ASCVD score? And if so, why would there be patients without lipid labs?
Yes, so good question. There is ASCVD scoring as part of the both within cardiology as well as within primary care, and we don't know the reason why the labs. That was one of the things that we uncovered through this, was why patients did not have labs within a 1-year time frame, how much of that was patient compliance, how much of that was missed by the primary care provider. And a great question. They should have had that, but the ASCVD scoring was what is part of an annual screening process, and that's where we were able to present that data today.
Okay, we have an additional question from the audience. Are there protocol parameters requirements that have to be followed for the AI coronary calcium score to be successfully generated, such as slice thickness and spacing? Absolutely. We have inclusion and exclusion criteria for the AI algorithm. We've made them as broad as possible. So any standard chest CTs in the US today, it's 3 to 5 millimeter thick slices work. Our original algorithm only went to 3 millimeters. We found that some institutions are still going at 5 millimeters, none that I personally work with, but it turns out there are. So we increased our algorithm in the next version to 5 millimeters, which is still accurate. So we also do low dose CT scans and cover that as well. So for lung cancer screening studies, we're able to generate the results as well. So yeah, we're pretty broad, pretty standard chest CT scans performed for any reasons, and as well as lung cancer screening, then we're able to generate the results. Let me see if there are any other questions here. None from the audience. Okay. Dr. Blankstein or Dr. Langholz, will you have any other questions you'd like to bring up for conversation?
I had one for, oh, go ahead. Sorry.
No, please, you go ahead.
I had one for Dr. Blankstein. I wondered about the adoption of AI technology into the clinical space, and whether that be by the imagers and how they are viewing that in terms of their workflow, and by the downstream end users for the clinicians that are seeing that data. What's been your experience with that?
Yeah. I'll start with the kind of the second part, which is the downstream clinicians. I think clinicians generally like more data. Maybe I'm biased as a cardiologist, but I think cardiologists, but I think it's also true for my primary care physician colleagues. They like more data, especially if it's actionable data. They don't want just data to say, what do I do about it? But I think with calcium scoring, with patients having plaque, we know it's actionable for prevention. So they like that. In fact, I often get asked by some of our primary care physicians, hey, this person had a chest CT. Do you mind looking at it to tell me like what the calcium score would be? Because I don't feel like sending them for a full calcium score. I think we all kind of get asked questions like that occasionally. Now, the second part of your question is the adoption by the imagers, which in this case is usually going to be the radiologists who are reading chest CT. It's most likely will be thoracic radiologists or general radiologists. And I think there's different kind of thoughts about like adoption. I think a factor that frankly a lot of radiologists or any clinician will think of is at the end of the day, will this make my day longer or shorter? Like how much more time is it to read this information? I think so. The big thing is how's the workflow here? And one of the things about Nanox, it's a single kind of page that can get deposited within your PAC system. So it's basically a screenshot that you could look at that has all the information, then allows you to make whatever, it can be integrated into the report, or someone can just dictate, one line about how much plaque there is. So it doesn't take a lot of extra time. It's really seconds. And that's really important because anytime someone has to by themselves do too many clicks and kind of segment vessels or do anything that takes more time, that's always kind of a killer for implementing these sorts of things. So I think this is very quick, which is really important. But you are going to spend a couple extra seconds. I think this is true of all of AI. For example, if you're looking at lung nodule detection, we have a software for that as well. That is going to take some time because when you finish reading the chest CT, you're now going to look at the algorithm to see what did the algorithm identify. Did I identify that as well? So almost any AI technique adds a couple extra, at least seconds. Hopefully it's only seconds. But then the question is, well, what do you get in return for that? How is that going to help me as a radiologist reporting this? And I think what you get is first, more consistency in reporting coronary calcifications, because we all know that this is not consistently done. Perhaps a little more confidence if you're going to state not just that there are calcifications. I always teach all our trainees to say, is there mild, is there moderate, is there a severe amount of calcifications? I think that's much more actionable than just saying there are coronary calcifications. So this gives you the confidence, which not everyone has unless they've been trained in cardiovascular imaging, to actually estimate how much plaque there is. I think you gain that aspect of it as well. So ultimately, when you ask, and I've had this conversation with our radiologists, you ask different people, is this a good thing or a bad thing? I think on the whole, most people are excited to have this because they now know this is important. We want to report coronary calcifications. But the big question is always, how much more work will this take for me? I think that's the number one question that every person asks.
Thank you.
I think the other challenge that we're having with this algorithm in general is who's actually paying for it. Because radiologists don't see any personal benefit from it. So the radiology department or imaging department is not interested in paying for the product at all. Cardiology does see a lot of benefit from it, but oftentimes there's many cardiologists in many different groups without one leadership that necessarily pays for it. In institutions that has a strong leadership or population health department that really can see the bigger picture, that's when we have the most success, because that they see the broader perspective, the broader effect on healthcare, the broader effect on the finances. And so that's the best ability to kind of infiltrate it into any institution. So if they can find the clinical champions that tend to start with cardiology because they understand it the most, and they are strong clinical champions, and they can then take it to their leadership and get the financing involved. It's really not that expensive, and it really has a very big impact. So we just need that extra push from cardiologists to the leadership to be able to put that in as a line item budget for the following year, and then we can definitely show value once we're inside. So that's really, really helpful. There was another question from the audience regarding additional algorithms. So this is our single algorithm in the cardiac world, although we are happen to be working on something else now, but that's confidential for the moment. But each algorithm is individually designed, it's individually validated and trained, and individually approved for FDA. So each one stands by themselves. So we don't have an additional cardiac algorithm right now, although there is something in the works. We do have other products in the world of osteoporosis that evaluate the thoracic and the lumbar spine on all chest, all abdomen, pelvic, and all contrast and non-contrast CT scans. So really a wide net of patients for vertebral body compression fractures and low bone mineral density. Because if you think cardiovascular disease is underdiagnosed, turns out osteoporosis is even more underdiagnosed, and really leads to a lot of morbidity and mortality in a lot of the elderly population. And we have a more recently approved fatty liver disease algorithm that does overlap in the world of cardiology and primary healthcare. And we evaluate the liver in both contrast, in both non-contrast as well as portal venous phase contrast CT scans in the chest and the abdomen. So we kind of really have a large group of patients that we can evaluate for fatty liver disease. Again, a lot of overlap with metabolic syndrome and cardiovascular risk factors as well. So that could be a sister product with regard to evaluating patients in preventative cardiology and assessing patients' long-term status. I think we're kind of towards the end of our webinar. I'd like to thank really from the bottom of my heart, both Dr. Langholz and Dr. Blankstein, who joined us and have really spent a lot of time, effort, interest, advice in the past couple of years with our company, with Nanox AI. Their help, their advice, and their expertise has been invaluable. And I hope that was portrayed and relayed in this webinar to all the audience today. So thank you very much. And thanks to SCCT very much for helping us create this webinar and have the audience. We look forward to seeing everyone at the SCCT. In fact, I just want to share one last slide with you. 1 second. Hold on. There we go. I will be at the SCCT with some of our additional Nanox members. If you'd like to reach out to us, you can reach out to us by email, or we can schedule a meeting at the SCCT to discuss, to answer questions, to consider implementation, research projects, and so forth. So we will have a meeting room there. We're happy to meet any of you that would like to meet with us at the SCCT in July. We look forward to meeting you, and thank you very much for attending.